Hello, this is Ed Rigsbee. This is another episode of Raw and Unedited for Association Executives. This is a place where we give you tips, tactics, solutions, all kinds of tools and everything else to help you to be a better trade association or professional society executive. Let me ask you, how's it going with healthcare? I mean, have you thought about healthcare for your staff? What about healthcare for your members? Are your members dealing with healthcare for their employees? Well, to deal with that, today we have got Dr. Josh Luke. He is the author of the new book, Health Wealth for You. I'm going to put it right in front of my face. There we are. This book comes out very soon, or I think it just came out.
Yeah.
And just came out. So you, like my wife, when I talked to her about this book, she says, "This is a book I want to read." I said, absolutely. Everybody in the United States should read this book. So Josh, let's bring it over to you and let me ask you the question. So what can trade association executives do? You know, what have you learned as a CEO of a hospital that will help them make better decisions as far as creating and healthcare for their employees, and just as importantly, helping them to help their members to create reasonable healthcare for their employees?
Such a great question, Ed. Thanks so much for having me on your program. This is the whole reason I actually started writing the Health Wealth book series, because Forbes saw me on social media, LinkedIn and Twitter, and said, hey, there are a lot of new solutions to bring the cost of healthcare down for businesses and individuals and not-for-profits like trade associations. But because those sharing them are brokers and benefits advisors, they're not getting a lot of traction because people are a little hesitant to change. And Forbes asked me to write a book in 2017 called Health Wealth, Is Healthcare Bankrupting Your Business? So both of these books get right to the heart of how can we save money for employers and employees that work for them, because really it's actually a harmony for both that they work together. But there are so many new tactics and new options to save money for employers on healthcare that these two books write about those different options. And literally there's options to save up to 30%. And the most important thing I'll say about the cost of healthcare for businesses and trade organizations is it's likely the second largest expense in your whole business model. And of your top 3 or 4, it's the only one you can't control. I mean, the old joke is every year you get taken to a nice steak dinner by your broker, right? And at the end of the dinner, the broker hands you an envelope that says, hey, here's your premium increase for the year, 5 to 10% every year for the last 15 years. Oh, and at the bottom of the letter, Ed, we listed the 2 bullet points of the benefits that you used to have that you're not going to have anymore after you pay the 8 to 10% increase. So what we've done with the Health Wealth book series is we've identified a number of different ways to stop that hyperinflation for your business and for your employees.
So Josh, you mentioned in your book, cost-sharing community model, and you talked about legislation that's new that will help associations. Can you speak to that a little bit? Because I know that I've seen at ASAE's some of their postings and talking about what's coming down the pike, but I haven't really seen much to really understand what's different and how that affects me as an association executive.
Such a great question for association executives, because it actually has happened very quickly. And one thing about me is I'm a healthcare policy professor at the University of Southern California. I'm not political, but it's my job to interpret policy. So I just want to get that out there, because the next statement I'm going to make, I want to make sure everybody heard that. As soon as the Trump administration, the GOP majority came into place, everybody knows they wanted to undo the Affordable Care Act. 3 times they tried and they couldn't. So what they started doing is looking at individual things, and there's 2 things that have happened that really opened the door for associations, and that is, number 1, they ended the mandate that says, hey, you all have to have health care. Number 2, they opened up the door to association healthcare plans, and really quickly. different programs like Fit Health through Sedera Health came about. I'm actually a member of Fit Health because I'm a solopreneur. I'm an entrepreneur. And this cost sharing program is not traditional insurance. And if you look back at many people understand that there's traditional insurance, which is HMO or PPO. And then in recent years, you probably heard about the cost sharing kind of faith-based plans like MediShare and those that aren't insurance, but if there's a large enough community of those that want to sign up for a Christian-based community or another religious-based community, you can cost share there. But these two moves by the GOP majority since President Trump's election opened the door for non-faith-based cost sharing. And that's what my wife and I have signed up for. And it feels a lot like insurance, but it's very modern and up to date.
Got it. Okay. That's fascinating. What are some of the important things that, I'm going to ask a different question. I want you to explain, in your book I read, engaged healthcare consumer. You call that an EHC. And as I was reading that, it hit me, okay, I never ask. I don't really pay attention to what things cost. And I guess, I hate to say it, Josh, but I'm just as guilty as the next person.
Everybody is, and it's not just you. You can sleep at night again. That's the whole point of the book, right?
Well, let's talk about this.
Yeah. So I tell a great story when I speak, and I learned from the best about how to speak. Ed's one of my mentors, and one of the cool things about my message, particularly with this new book that just came out February of 18, and Ed, thanks again for the mention. It hit bestseller on launch day, so I'm really excited about that. But this book is written for everybody. It's written for everybody to say, hey, you can save money for your family, and here are 11 different steps that you can take to live healthier while you're saving money. And as I finished the first Health Wealth book, the one that targets employers, I realized when somebody said, hey, what's it about? Write a summary. I said, well, it's about engaging in the process, right? And somebody said, okay, what does that mean, engage in the process? And I said, well, it comes down to the 3 Ps, having a plan based on preventative medicine and personalized medicine. And so that really is a very vague way to understand what these 2 books are about. But I want to tell you a story that really hits home with what Ed just described. In one of my speeches, when I someday give a TED Talk, the leading name I throw out there is the 8 words that killed American healthcare. Don't worry, your insurance will pay for it. Those 8 words duped us all, Ed. I'm a Gen Xer. I'm going to guess, based on your very youthful appearance, you're probably a baby boomer. So for the 2 generations that we grew up in, we all were absolutely duped that our insurance was going to pay for it, because when we all chose that shiny hospital on the corner for our procedure, it may have cost our employer or our insurer an additional 60% over the community hospital down the street. And by the way, their quality scores were the same. The physicians were the same. But we just said, hey, our insurance is paying for it. I'm going to go to what I perceive to be the best. And this actually, Ed, is what led to the rise in high deductible plans, because the employers and insurers said, hey, make Ed feel the pain a little if he chooses that big shiny hospital. Make him pay more, and now he will engage in the process. So as a public speaker, one of the things that I've been taught by my mentors is simplify these things so when people can leave and somebody says, hey, Josh was a great speaker, what did he talk about? Oh, he talked about an EHC instead of something about engaging in the process. An EHC is just my term for an engaged healthcare consumer. So here's the story. It's a great one. I'll make it quick. So it's your 16-year-old daughter's birthday. And you promised her, mom and dad, that you would buy her car. She shaved the money. You saved money. You promised her you'd pay for half of it. She went on the internet, printed out the exact car she wants. She's got those 5 pages printed out. Day of her birthday, she goes to the DMV. She passes the test. She's home by 9 a.m. Mom, dad, it's time to step up. Get in the car. We're going to get that car. So dad's driving, mom's shotgun, daughter's in the back, windows down. You pull up to the stoplight on Auto Center Drive, right? And on the left, out of the back, your pride and joy back window, your daughter's hanging out. She's going, daddy, daddy, there it is on the left. The exact car I want. Same color, same tires, same rims, even my favorite radio station playing, and in big red and yellow numbers on the windshield, it says $16,000. Well, right then mom steps in, and mom says, hey, look, guys, it's on the right too. The same exact car, same color, same tires, same rims, same Taylor Swift playing on the radio. But in big red and yellow letters on the windshield, it says $42,000. And, here's my question for all the dads listening right now, Ed. Which way are you going to turn? Because most dads I know would have not even heard mom speak, right? They'd have been like, oh, I didn't hear anything. I'm turning left. And I'm going to ask that salesperson, what's the difference between your car and the one across the street that's priced 60% more? But Ed, it gets back, doesn't this story get right back to what you just said, is I've never engaged in the process. I never shopped like I would for a home or a car. And when we're duped into thinking our insurance will pay for it, we will turn right and say, hey, I want the Cadillac version. Must be the Cadillac because it's priced higher. But again, I will repeat this. Quality scores for hospitals on both sides of the street are almost always identical, and the same physician will operate on you at either hospital. So engaging in the process saves you money as an individual consumer and employee, and it saves your employer thousands.
So that's great. So Josh, in your book, you talked about, and it says blockchain for improving one's health. I didn't get that one. Could you tell me what you meant? It's
really hard to simplify in a show like this, but there's so much blockchain technology out there that blockchain, for those of you who haven't read about it, in the media, is just technology that gets smarter as you go. It's almost real-time technology. It's almost like building blocks. So for healthcare, it's finally to a place, Ed, where your personal electronic medical record and the information accompanying it from your caregivers and friends just becomes a big anthology of your history. So we learn a little, then we learn more, and we learn more. Traditionally, healthcare delivery was so fragmented that you could go to one doctor and he or she might not know what happened at the other doctor a week before. Even if they work with them and know them, they didn't have the technology to communicate, to share. And I'll be frank, we're still getting there on that record sharing. It's very rare that a post-acute provider does have integration with an acute provider even to this day, but within the next few years we'll be there because there's a lot of mandates coming. So my mention of blockchain was simply to say it's only a matter of time before patients own their own health record finally after all these years, and B, it's a smart record that gets smarter as you go instead of fragmentation that you have to look everywhere to find what you want.
So on that, that resolves the situation where somebody goes to one pharmacy and gets a drug and goes to another pharmacy and gets a drug that doesn't work with it.
Well, and that's a really good point, Ed, because with opioids, that's kind of the first time that became possible. It wasn't even for the point you made, which is life and death, which is not that opioids isn't, because it certainly is, but adverse medical reaction. So I think what happened is when we had these medication seekers coming to our emergency rooms and to different pharmacies, the feds really quickly, and the states got technology so different pharmacies could type in their social security number and see if they were over medicating. And now, because we have that technology, yes, you have the ability to, and we're still just getting there, but you have the ability to compare meds and make sure you're not on a regimen where there's another med that might have an adverse reaction to a newly prescribed one.
Is there, as this blockchain comes into play, is that going to collide with some of the HIPAA regulations?
Yeah, so another awesome question, because those of us within the healthcare industry a lot of us would describe HIPAA as the biggest overreaction to a policy in the history of the world, which is, you can't sit in the same room in the waiting room with another patient because therefore you've seen them. But the whole point of it was, hey, look, Ed has the right to keep his health information private. And so as long as it's secure communication, which pretty much everything is, because everybody knows it's a non-starter moving forward, you're consenting at some point to this pharmacy being able to have access in that pharmacy. So the answer is yes, this is all going to be HIPAA compliant.
Got it. Okay, so let me get into the next question. In your book, you talked about local medical tourism. Now, I've been to Bangkok before, and I've got a friend from the UK that, well, he gets free medical in the UK. He pays extra for a policy so he can get in to see the doctors in front of the, as they say, queue. But then he also goes to Thailand to have a ton of work done. Now, and so I've heard the term medical tourism. LA Times has talked about it. But when you say local medical tourism, are you talking about going to other parts of the United States, or are you talking about going out of the country? Talk to me about the medical tourism as you
Awesome.
said.
And you gave some great points. So local medical tourism emerged out of what you just described that your friend does in a socialized medicine environment, which is concierge medicine, where when the government provides it for free, whether it's in Great Britain or Canada, if you have the money and want a little more of a premium service, valet service, if you will, concierge service, you pay a little more and you get to the front of the line. What evolved from that was, hey, you don't have to be rich to get better enhanced access to what we call centers of excellence. And Ed, we actually already described a center of excellence when I told the story about our hypothetical 16-year-old daughter's birthday. Because what high deductible plans have forced is the engaged healthcare consumer to say, hey, I could go to the shiny hospital that I always perceived to be better, likely because they have more advertising at the ball game when you go. That's the only reason, right? On the outfield wall. Or I could go to my community hospital, and guess what? I just learned my doctor goes to both, and I just pulled the quality scores up on both hospitals, and they're either the same or my community hospital's actually a little better. And Ed, I'm not here to put down the big shiny hospital, but what we've found with these centers of excellence is when they engage with your business and with you as an employer to give you a discounted rate, they've also engaged on quality. They've also engaged on customer service. So the body of evidence that exists, which is still small, would suggest that actually it is that center of excellence that may often not be the perceived biggest, best hospital in town who is scoring better across the board and giving you a discount. So the short answer to your question is local medical tourism means shop within your market and find the facility that is the center of excellence. And for some procedures, Ed, you might pay 60 grand, the employer would, at the big shiny hospital, and your employer would only pay $15,000 at the community hospital. And so what a lot of these new plans do is say, hey, Ed, you got to pay 5 grand out of your pocket if you go to the big shiny hospital, but we'll let you do it for free at the community hospital or a $1,000 copay. And here's a little tip for your listeners, and this is the kind of stuff you get when I come to speak. If you're in that organization with the high deductible plan that has a 5K copay versus a 1K, when it's your time to pick a procedure in a facility, go to your HR director or your benefits provider and say, hey, will you waive my $1,000? And you may, in fact, be more educated than them because they might say, why would we do that? And I just described to you the answer. They're paying an extra $40,000 for you to go to that other facility. So for them to write off your 1K, smart decision on their part.
Well, just to follow up to that, what about paying cash? So if I were to go to a hospital, are there, I mean, I hear about it. I don't know for a fact, but I hear people talk about cash discounts and cash prices being dramatically lower than stated prices.
Yes, that is correct in almost all cases. As part of my cost sharing plan, the way mine works, Ed, is, and again, these cost sharing plans really open the door for associations. They're even called association health plans in many cases. I pay cash rates to my doctor appointments and tests. And then at a certain threshold, I can submit for reimbursement. And what I learned, because I've only been in this cost sharing plan for about 6 months, is almost every provider will say the cash rate is X, but we give 20 to 30% off. And so there's a sense that if you don't have insurance in America, oh, poor you. The reality is I'm of the school of thought that sometimes when you do have insurance, or oh, poor you, because it's costing you so much of your paycheck and the co-pays, that when you just go to a cost sharing plan, it's essentially almost like every other form of insurance, which is it's only catastrophic, which means I might pay 5 to 10 grand a year for cost sharing, and after that I'm covered. But guess what? I'm paying just as much or more than that for my traditional PPO or HMO. So yes, cash rates are often lower. For example, my daughter needs an MRI right now. My wife said to me yesterday, needs an MRI. I said, what's the cash rate? $400. I've been running hospitals. We were charging $1,200 to $4 grand for an MRI.
Got it. So what are some of the new healthcare benefits that employees are talking to their HR or others about? What are people wanting?
So cool that you asked that, Ed, because the millennials as of 2018 are the largest generation in the American workforce. I don't know, most people don't know that they are the largest component there now. And their upbringing was with an electronic device in their hand, not always driving places. So many of them don't even get driver's licenses for several years because they're used to physical activity. So that said, the employers are having to be receptive to some of their requests, and personalized medicine and preventative medicine has really emerged. And so let me give you 2 or 3 of my favorites. We've already talked about telehealth and remote monitoring. You know, it's hard for us as boomers and as Gen Xers to go, really, a doctor over the TV or over my phone? But guess what? If I went on my phone right now, I could have a doctor talking to me in 2 minutes, and I could be done in 10 minutes and at the pharmacy in 15 minutes, right? Or I could do the traditional method, which is to call my doctor. Maybe he or she can fit me in today, cancel my plan, sit in the germ-infected waiting room. So telehealth is one of them, but let me give you the 2 or 3 that are my absolute favorite. The first is DNA testing or full genome sequencing. We hear this and we go, wow, that's way out there. It's actually not way out there at all. There's several consumer-facing products that you can get, like Ubiome, Helix, Color, or Biome. They send it to your house. I have one sitting on my dining room table right now that I'm going to do. You swab your cheek, you send it in. They send you a diagram of your DNA. So pharmacogenetics is one, Ed. And what pharmacogenetics means is once you've done that, they'll say, hey, Ed, FYI, Advil doesn't work for you, but Tylenol does, and 300 milligrams at a time is ideal because that's how your body metabolizes it. So that's real science. It's not witchcraft. It's not in the future. Pharmacogenetics. Yeah. Along those same lines is the gut. People are learning so much about their gut, and it's called the microbiome, BIOME. It tells you there's thousands, if not millions, of different organisms in your gut, and this tells you how that combination in your body breaks down each food. And, you know, I heard about this actually from a professional athlete in the late 90s who was telling me, I was doing some work for him before I went into healthcare. And he said, my wife and I each paid like 10 or 20 grand, a PGA Tour player. And we had this test, and it's weird because like corn, you don't think of it as necessarily a healthy food, but for me, it's a fuel. For my wife, it's not, it's a blocker, are the words he used. And granted, that was almost 20 years ago, but this science has been evolving since then. So that's actually called nutrigenomics. So there's 3 areas that if you're interested in follow-up on, we can talk about pharmacogenetics, the microbiome, and nutrigenetics. And they're all very similar. You just get a roadmap of your body, and it says, hey, here's what works for you and here's what doesn't.
So I'm taking this away for just 1 second from the association execs talking about my favorite topic, me. So, so just on this, so the paleo diet that I'm on to keep my weight down because of my blood sugar. So that sequencing would give me a better idea of if that diet would work for me, or if even though it has, but that would be able to take me deeper.
Yeah. For sure. One of the experts I've had on my podcast, I have a podcast called A Benny for Your Thoughts podcast, where we talk about personalized health in preventative medicine, benefits for employers and associations. And one of my nutritionist guests said, hey, diets are all about perfection. Ed, I'm like you. My favorite topic's me, and I'm guilty of binge dieting all the time, losing all this weight, and over a couple of weeks or months, I gain it back. She said binge diets are about perfection, and really all of this personalized medicine we've talked about is the solution to long-term sustainable weight loss and health, to live at a healthy level. So yes, I think there's a decent mix of both, but this personalized medicine approach is just one I can absolutely attest to. I've had people come up after I speak, and you know, Ed, you've spoken long enough that when you tell a story that hits somebody at home, they've got that tear in their eye before they open their mouth. This DNA testing thing is real. And I learned that. I've been doing this whole healthcare affordability presentation since the beginning of 2018. And I've probably had 5 or 6 of those moments where that person approached me and said, what you talked about changed my life.
Wow. Hey, Josh, on that, but I'm going to take a little bit of a turn here. What's going on with employers and offering healthcare stipends and so forth? Is that happening? Is that going to grow? Is it going to decrease? Where are we with employers offering healthcare stipends? Yeah,
so the Affordable Care Act kind of started walking you down the path to that because of the mandate. It said, hey, but if you're only this big or that big, depending on the size of your business, here's some options for you. And then again, with the GOP majority coming into place in 2017, no more mandate. We're going to open up something called association health plans to create some competition. And so one of the things that has emerged is, and this is great for working parents that both work, where one might have a good benefit, especially if they're a public servant. And the other can say, hey, I'll take the $300. We used to call that cash in lieu, right? I'll take cash in lieu of a benefit. But now it's cash in lieu of a health insurance, but it has to be used for health insurance. And that's what's really opened the door for employers have realized that, and this is such a great topic for associations to bring at your annual meeting. Here are the options that you have. And guess what? Your employees might like that $300 a month way better than the $600 plan that you've given them that's frustrated the heck out of them for the last 5 years, because they can go get a cost sharing plan like I have, or they can go shop it to a personalized plan. And so such a good option. Each state has different regulations on that, Ed. So you're going to want to really check it out as you move in that direction. But gosh, I met with the pastor of a mega church a couple weeks ago, and he said, Josh, in the not-for-profit world, these are retirement healthcare bennies. We're just not getting any of this conversation at our annual meetings. There's so much of a leadership focus that this is leadership. We've got to infuse this. So I think it's a great time for your association followers, Ed, to be listening to this specific program to hear these different ideas.
So for the association executive that's sitting watching this, what can you tell them to tell their members as far as trending with on-site clinics?
Oh, such a good question.
I understand that that's an emerging trend. And can you talk about that to help the association execs understand what it is and how they might make some recommendations or where they can help people?
Yeah, for sure. So in both books, both of the Health-Wealth books, we talk about on-site clinics as a driver to drive your costs way down. And so if you're considering your own on-site clinic, here's kind of the threshold industry and nationwide. If you have 400 employees on one location or one site, that's enough to justify an on-site clinic, because remember, this is for their family members as well. Or if you have 500 in, let's say, a 5 to 10 mile range in the same area, they might be dispersed, so there won't be 400 on one campus, but maybe 200 there, 200 there, 100 there. Now you have enough to justify an on-site clinic. Here's the other one that I think is a no-brainer. Go to a commercial complex and put a on-site clinic there. So if you are an employer, or if you're an association who has employers who you know might not be at 400, but might have 100, 150, and they're in a big major complex or even in a high-rise or an office tower, just ripe for opening an on-site clinic that is shared with 2 or 3 other employers, because there's an emerging practice called DPC, direct primary care. And what happens when you get an on-site clinic is you go to a doctor and say, hey, doc, good news. We're calling you. Why don't we pay you $250,000 a year between the 3 of us, and our employees and family members can walk in between 6 a.m. and 10 p.m. to your clinic. And we will also give them telehealth and remote monitoring overnight, 24/7. And you can close down your private practice and move here, and that's it. You don't have to bill insurance. You don't have to do anything else. It's called direct primary care. And what we're finding is that physicians and again, there's a whole chapter on this in the book on DPC. Physicians are spending 15 to 20 minutes with each patient in some cases, as opposed to 3 minutes while they're looking at their watch and their pad. So great question about on-site clinics. Great discussion for associations.
So let's follow that up. You talked about the chapter of the book, and I'm going to bring this interview to a close very soon. But I just a couple things. So I noticed you gave me a one sheet that was with the, and you made a comment that if somebody brings you in, what was it, 250 free books at no charge with keynote bookings. Now, we're recording this in 2019. For how long is this offer good?
That offer is good throughout 2019. I was just in Nashville last week, and for those of you who are interested, this book was written so I learned so much from Ed and others about, hey, if I need my message to be relevant to every single audience member, number one. And number two, my goal is to entertain. When I emerged out of the hospital C-suite as a speaker, it's because healthcare executives were demanding it. But then I said, well, this is fun, and people are laughing at my stories, and they're saying your stories are relevant, but more so, you were fun to watch. And so I learned from mentors like Ed about how to be entertaining. I will tell you, I am 100% an entertaining keynote speaker that has fun, but you will leave with the book, and you will leave with 3 or 4 concepts that will stick with you, many of which Ed and I have talked about today. And I want to share one thing with you, Ed, that now is the number one thing I'm getting requests for. I went back and did a musical parody you can find on YouTube. Just type in Dr. Josh Luke on YouTube. It's called Welcome to the Hospital. It is a rewrite of a 1980s rock and roll song that many of you know, right, called Welcome to the Jungle. And it just flat out makes fun of every single thing that Americans hate about healthcare. And I launched it in early 2019. It went viral. It's still picking up 300 or 400 views a day, but I'm actually having people demand that I either perform it or play it. And after performing it once for the video, I'm like, I can't do this again. This is really embarrassing to be lip syncing a song in front of 2,000 people. But I played it in Nashville last week and got a standing ovation at the end of it. And that was my goal, Ed, to take the things that you taught me, Josh. You have the info, learn how to entertain people. And I'm finally there, and I'm thankful for you and others that taught me how to do that. And now I have a message that is relevant to every association nationwide.
Thanks, Josh. Well, you know something, as I said, when my wife asked, yes, you should read it. Yes, every American should read it. For all of the association execs, you can see behind Josh, www.drjoshluke.com, health-wealth.com. Can I give on your business card the phone number?
Sure.
Okay, Josh's phone number, 714 area code. God, I can't even read it. I need readers. 686-4278.
4272. 4272.
Hold on.
Wait, I'm blowing up already, Ed. Is this live?
On.
I'm blowing up. I'm just kidding.
Hold on. Oh, you're right. It is a 2. Okay, so and it's Dr. Luke, Dr. Luke, Luke, at health-wealth.com.
Awesome. They know how to get a hold of me now.
Got that. So no, thanks, Josh. I really appreciate this, and this is a conversation we could have for hours. I could see this at an association meeting. Actually, not to tell you how to do your marketing, but what the hell? No, I can see this as a keynote, but after you do an hour or 45-minute keynote, it needs to be followed up with a workshop. So,
all the time. I'm so glad you brought that up. I was like, I got to get this one more point in that I do it all the time. I would suggest that to people. If you want me to do an hour after the keynote on DPC or on an on-site clinic, or sometimes people just say, let's just open it up. There's questions. So thank you for mentioning that.
I think that would be a great way to use you. So to everybody out there, this is Raw and Unedited for Association Execs. Ed Rigsbee's guest is Dr. Josh Luke, and again, his book, Health Wealth for You. Thank you, Josh.
All right. Thank you, Ed.
Oh, no, I didn't do that right. You're still hearing us because Ed forgot to push the right, didn't push the right button.
Do you want me to sing while you push the button?